Welcome to the Self-Carapist Podcast. Join me, Lorraine Moorhead, a licensed psychotherapist, clinical supervisor, and EMDR consultant, along with expert guests as we explore the approaches and modalities we've used and developed to support our clients' success. Our conversations and stories are designed to inspire new and seasoned clinicians to stay curious, prioritize self-care, and never stop learning. Dr. Sonia Lott, PhD, has been a licensed psychologist for more than 30 years and maintains a multi-state online private practice specializing in death-related loss. She is an affiliate of the Center for Prolonged Grief and an adjunct faculty member of the Columbia University School of Social Work. She is also a contributing author to the 2024 edition of Living with Grief, Understanding Prolonged Grief Disorder, published by the Hospice Foundation of America. In this episode, Sonia gives us diagnostic criteria and considerations, outlines some outdated approaches to grief, and provides us with actionable and accessible steps to further our grief training, along with a call to action to encourage any interested therapists called to do this challenging work to pursue the evidence-based trainings. This conversation has mobilized me, and I can't wait to hear from all of you. And I will warn you, there is some heavy content because it is talking about grief. If this episode inspires you to want to read some of the research or take some of the trainings mentioned, head over to my website, lorrainemoorhead.com/podcast, and download the learning tracker that features all the key resources from each episode. Welcome, Dr. Lott.
Thank you. I'm grateful to be here.
I'm so happy to have you here. Can you give a little bit of a background on how you got into the grief work that we'll be talking about today?
Oh my goodness. Okay. So I'll make a long story very short. When I was 21 and in graduate school, started my master's program, I got the message that I was supposed to specialize in grief. Because I knew when I was 9 years old that I had to be a psychologist. It was like the easiest decision of my life. So once I was in graduate school, I got that download, and I thought it was a miscommunicated message, because I hadn't experienced living, dying, loved ones dying or anything, and I just didn't think that it was the appropriate thing for me. And but I took a death, dying, and bereavement course and cried every time I opened the book, which seemed to validate my initial idea that this was not for me. And so I ended up teaching for several decades developmental psychology from an integrated perspective around death, dying, and bereavement at every age. And I thought that was the yes to the calling. And then in 2015, when my mom died, I realized in that moment that I had everything that I needed to, once I got off the floor from that profound loss, to do the work. And so that's what I did. So it's been this for the past 10 years.
Oh, so interesting that you had that epiphany that was coming for you, and then you knew when you were ready to do the work.
Yeah. And I had experienced many losses prior, and really thought I was doing the work, with the teaching and working with my students and, that type of thing. But it was Mom's passing.
Yeah, I can relate to that. There's something about losing a parent that illuminates the need for that work.
Yeah. My dad had died some years before, but that's, that was a really profound loss also. But that preceded Mom's by about 23 years. So I still had some growing to do before, I would be ready.
Yeah, I can understand that. Will you walk us through the timeline of the origins of the prolonged grief disorder diagnosis?
Yeah, I promise to be more brief here. It was around 1999, year 2000, when the concept of some type of grief separate from quote, typical grief, or the complex grief experience that the majority of people have when someone who they have a very close relationship, maybe conflictual also, but a close relationship with dies. It was referred to then as traumatic grief. Catherine Shear, psychiatrist who developed the prolonged grief therapy protocol, and Holly Prigerson, she's at Columbia. Holly Prigerson, who's at Cornell, was a medical sociologist doing a fellowship. They were all at the University of Pittsburgh. So they became the two, along with Charles Reynolds, a psychiatrist there, to really begin to dig into what this might be. And was this depression or something different? So it was initially referred to as traumatic grief. After some time, it was referred to as complicated grief. And then the DSM-4, I think it was the TM, Treatment Revised, included the idea of persistent bereavement disorder as a name for that, complicated grief or traumatic grief. And it never really, as a condition that required further research, and it never really caught on, that term. And though the diagnostic criteria is very similar in the DSM-5-TR, where prolonged grief finally appeared as the official diagnosis in 2020, the criteria for prolonged grief disorder is very similar to persistent bereavement disorder. The ICD International Classification of Diseases also selected the concept of prolonged grief disorder in the same year, but with a slightly different diagnostic criteria. So now the terms of traumatic grief are being used in a different way, and the idea of complicated grief now is being used in a different way. It's interesting.
What way are people using it now, would you say?
Well, some of the people who specialize in what they're referring to as traumatic grief right now is defined by the death of a child or a violent death of a loved one, by homicide, by suicide, car accident, accidental overdose, that type of thing. So that more in the way of PTSD, like, if you will, the trauma itself being the way that, except for a child, the way that the individual dies versus the experience that the grieving person has after the loss of a loved one, however they die. And so complicated grief now has become this sort of catch-all phrase for any type of grief that's hard, which from my perspective is all grief. So, grief that's messy but doesn't fit the diagnostic criteria for prolonged grief disorder. And I think a part of that also is the sensitivity to not wanting to, quote, pathologize grief. And some people believe that, prolonged grief disorder pathologizes, quote, typical or normal grief. But that's not the intention.
Yeah. Can you describe a little bit about the intention and what prolonged grief disorder is?
The intention is to provide clarity around a particular subset of people that's been estimated to be about 10% across cultures of people who are grieving, who get stuck somewhere in the process or derailed from the process of the typical complicated lifelong process of adapting to the loss of a loved one, and living the rest of your life in that unwanted reality, and then trying to restore a sense of well-being. So with prolonged grief, what happens is the person gets derailed somewhere along the way.
How would you describe prolonged grief, as compared to what you would consider a typical grief process?
Thank you. So the person gets derailed, okay? And the primary distinction is not just the length of time, okay? The ICD says 6 months. The DSM, which in North America, we lean toward the DSM, says at least 12 months, at least 12 months. But it's the intensity and the persistence of the grief-related symptoms to the degree that it impairs a person's ability to function over time, so that you don't see the change, the shifts that typically begin to happen after a certain amount of time. It's like Groundhog's Day. The person wakes up in the same state again and again and again. And so with the DSM, the criteria states that you have to have an intense level of preoccupation with the loved one or intense longing or yearning, okay, that is persistent past 1 year to the extent that it interferes with day-to-day functioning. And in addition, there has to be at least 3 of 8 possible additional symptoms that have been present every day or at least every day for the past 30 days, in addition to at least 1 year, that interfere with day-to-day function in a clinically significant way. Okay, so that's the intensity and the persistence. Okay, and the person is suffering in a way that's different from the typical grief process, if that makes sense.
It does.
And it's important because knowing that there are people who are either at risk for this based on the risk factors or who meet the diagnostic criteria, there's a very effective evidence-based treatment for that. Why won't we intervene? Why will we want people to continue to be misdiagnosed with depression or PTSD or have both of those conditions or either of those and the prolonged grief disorder? Why wouldn't we want to allow people to be appropriately diagnosed, to get the care that they need, to get the healing that they want, that they deserve, that we all want? That's what it's about.
Yeah, it's almost an both and type of approach where
Yeah.
we want to honor that there isn't any typical grief isn't linear, and we want to
Right.
honor that folks have their own, everybody goes through a different grief process, and we want to be able to offer some support when we do recognize that it becomes pervasive and is keeping someone from re-engaging in activity.
Being able to go to work, to
Yeah.
be able to interact with people, to decrease the likelihood of suicide, to decrease the likelihood of major depression because they've been treated with antidepressants or they've had 3, 4, 5 therapists and nothing is helping. A lot of times people, when we first meet in the consultations that I offer prior to deciding to work together, people will say, I've seen 3 or 4 therapists and this is it. If this doesn't work, I'm done. So there's this history of misunderstanding, both on the part of loved ones who are trying to be supportive and therapists who are trying to appropriately intervene. If you're offering the wrong types of treatment, then people lose hope. They feel that something is wrong with them.
From your perspective in your practice, will you work with someone who hasn't yet met the threshold for prolonged grief disorder?
Absolutely.
Yeah.
Absolutely. Yeah. And so I will tell them, you don't fit the criteria, but here's where you are at this point. Here are some of the risk factors that increase the likelihood that without an appropriate intervention, you will develop it. If it was the person died in a traumatic way, if the person who's grieving has had multiple losses, if they have a history of insecure attachment, particularly anxious attachment style, if they have had, they have anxiety or depression, why not intervene? And it may not mean offering them the full treatment protocol, prolonged grief therapy protocol, but the aspects of it that would be beneficial. Why wait if you know that there's a way to help them to alleviate their suffering and help them to get back on track?
Yeah.
Absolutely.
Is there a preferred measure that folks diagnosing prolonged grief disorder recommend or are using?
Well, you want to do a full assessment because there can be coexisting conditions. So you want to have some measures for prolonged grief, for major depression, for PTSD, that type of thing. But for the grief part of the assessment, the Inventory for Complicated Grief, which has been around since the early 90s, Holly Priggerson offered that, and it's got really good reliability and validity, is sort of a standard. It's in 19 statements that you endorse from never too often. Do you feel this way? I sometimes feel the same pain that my loved one had. I can't stop wishing they were still here, that type of thing. And a score of 30 or higher would be reflective of that condition, and so of prolonged grief disorder, an indication of it. But there's also Holly Ferguson also more recently developed the prolonged grief disorder inventory, and it's aligned with the DSM-TR. Okay. And so that's another instrument that is commonly used. Those are the two primary ones. But what we do with prolonged grief, and I do with anybody who's grieving, is I will give them the what's called typical beliefs questionnaires, a 25-item a set of statements that you endorse to, rarely to very strongly. Do you feel or think in certain ways? I should have expressed my love more. I should have done something to have made their living easier, prevented their death. I can't stop wishing he or she were here. My grief is the only tie that I have left to them. And so that's a really useful instrument, and one that's called the Grief-Related Avoidance Questionnaire. And that's 15 items, things that people have been avoiding related to their loved one. I avoid looking at photographs. I avoid engaging in activities in my home that remind me of my loved one. I have difficulty, or I avoid, going through their belongings, that type of thing. I avoid talking about my loved one, because avoidance is a really big part of trying to cope with grief initially, and avoidance works until it doesn't work anymore, right? Because it's very good for short-term coping, but dealing with the no longer having a loved one in your life for the rest of your life, you have to develop new long-term coping strategies. And so the avoidance ends up helping us initially and then blocking us somewhere down the road. So we want to make sure we're assessing where they're avoiding things to try to help them to begin to approach the things that they've been avoiding.
That was such a great comprehensive list of instruments. I think that's going to be really helpful. Just because I know someone is wondering as we're talking, are we talking purely death, or could it be grieving other types of losses as well?
There are many different types of grief, okay, of loss first that lead to grief. Anytime we give up voluntarily, or it's taken from us, something that we value, okay, person, place, or thing, situation, whatever, that's a loss. And there's a grief process that follows that and should be honored. The diagnosis for prolonged grief disorder is limited to humans and to the death of a loved one, okay? Though it's very common to see people who, as it relates to the death of a pet, are showing the same symptoms, and I honor that. We have a really long way to go, I think, in our culture, in recognizing that our pets are our loved ones. They are our family members too, and they can give us things that our human loved ones can't, true unconditional positive regard, for starters. But the diagnosis of prolonged grief disorder refers only to human death-related loss. So that's not to invalidate the impact of many other losses. And within working with people dealing with death-related loss, there are all types of secondary losses. There's the idea of the loss of the assumptive world, that if I do A, then B follows. Or if I'm a good person, none of my loved ones will die or die tragically, even though the reality is we all die. You know what I mean? We think, well, if I do things right, or if I'm a good person, or if I have good karma, then I won't experience that. So there's a loss of the assumptive world. There's a loss of one's own sense of identity, particularly if it was a partner with whom you had a really beautiful, like satisfying relationship with, or a child. You lose a part of yourself because so much of who you are is intertwined with who you were with that person. So there are multiple losses, that are part of death-related loss, but the focus here is on all of the losses that come as a result of the death of a loved one.
Yeah, that's really helpful for consideration. Will you talk a little bit about what the evidence-based treatments for prolonged grief are?
Yeah. What's now called prolonged grief therapy, okay, used to be called traumatic grief therapy, then complicated grief therapy. And then for just a hot minute, it was called prolonged grief disorder therapy. This was right after the DSM-5 TR, the official diagnosis. Kathy Shear, the psychiatrist who I work with at the Center for Prolonged Grief and who created the treatment protocol, tried to go with the flow. She was one of the people who wanted it to remain, the term to remain complicated grief. And she inserted the D for a minute, and then the D, just didn't work. And so she refers to prolonged grief disorder as prolonged grief, and the therapy is prolonged PGT now, prolonged grief therapy. So it's often referred to. I was looking at a study just the other day, systematic review of treatment and what, evidence-based or not for prolonged grief disorder. And most of the studies were those using some form of CBT. There's a grief related CBT that's very commonly used in Europe. Okay. But in North America, US and Canada, it's the prolonged grief therapy protocol, which is sometimes thought of as CBT, but it's not. It's a combination of it's grounded in many different theories and also many different therapeutic modalities. So it's grounded in attachment theory, self-motivational theory, and more. And the treatment protocol has some aspects of CBT, the exposure therapy, but there's also motivational interviewing, a dab of interpersonal therapy, and so it's a combination and psychodynamic therapy. So it's an integration of many different aspects, and the intention is to try to address all of the areas that a person may be struggling in. So CBT focuses more on maladaptive thoughts and behaviors, and the prolonged grief therapy focuses on the sense of the loss of identity. It also focuses on being able to create a coherent narrative of this person's death and what it means to live without them. It's also focused on rewards, helping people to go between, and this is a dual process model of grief, the oscillation between the grief focused orientation and then the restoration focused orientation. So it addresses more of the parts of the individual that need attention and support, if you will. In under optimal conditions, it's a 16 to 20 session treatment protocol. And my experience is it's more like 20 to 25-ish sessions. And that's because life happens, if a person, and if there's an anniversary date related to the death of the loved one or some other loved ones, who died before or since that, because we often see people who've been stuck in their grief for years, sometimes more than a decade. So it's not just like, when somebody's had the first anniversary and then they find their way for treatment because, that's one of the stereotypes that after a year we like stamp them. Okay, we brand them with the label and pathologize them. But anyway, so if there are anniversary dates that are coming up, like the death of the loved one who we're focusing on, then one of the techniques that we use called imaginal revisiting, that's like the exposure therapy where they're sharing the story of being informed of or noticing if they were with them that their loved one had actually died that moment. And whatever they remember going forward for 3 to 5 minutes initially, not a really long time. And that's the most stressful part of the treatment protocol. So if there's an anniversary date coming up, that's not the session to start that or do a second one or a third one. So we might need to pause. The person, if they have a lot of anxiety or if they are also dealing with a major depression, then we may not even get to the treatment protocol for 10, 15 sessions, because no matter what, if they have prolonged grief or not, whatever's most present is where we must start, as with any other treatment. And so we may not even start it 10, 15 sessions in, sometimes because it's a stressful treatment. It's not easy. It's difficult work because it's an invitation to be present to your grief on a daily basis. Who would want to sign up for that, right?
Sure.
So,
Sure, especially for those that you mentioned that have gotten so skilled with the avoidance. It
absolutely.
really is an undertaking to come in agreeing to really confront some of those pieces.
That's right. And a big part of that is the therapeutic relationship, which, as
Yeah,
it is with any type of work
sure.
that we do, they have to trust me first enough and then a little bit of themselves to say, yeah, we can do this, you know. So it's still short-term therapy, and that's the point, but not necessarily 16 to 20-ish sessions. Evidence-based in that there have been three randomized controlled trials done looking at the efficacy of it. One was with interpersonal therapy, another was with citalopram. And so they looked at efficacy with or without the prolonged grief treatment protocol, which is called complicated grief at that time, with or without the medication. And they found that the medication didn't, make a difference in terms of symptoms of prolonged grief. But if there's some depression, it helped with that part, but not the prolonged grief. So three studies, over 650 individuals, primarily women, who are the ones who show up for therapy most anyway.
Mhm.
And, so thus for grief as well. So that's the evidence for the efficacy of it, of the prolonged grief treatment protocol. With anything, it doesn't work for everybody. It's the same thing with any evidence-based treatment. But I found it to be quite transformational for people based on, what I noticed and then what they share with me about it.
Wow, that's a great endorsement that you see in your work that it's
Uh-huh.
making a big difference for folks.
I feel so much gratitude that I get to do this work. It's amazing, you know. And I had mentioned to you earlier that it's one of the reasons why I really want to. I try to pull as many therapists and pique their interest to consider completing the training and adding this to their work. You know,
Yeah.
um,
Give us the call to action.
Well, the call to action is it's worth it, and we need you to do this work. We need more of us to do this work. A lot of people are working in grief, okay, grief and loss. But if you know what prolonged grief looks like, and you're familiar with the treatment protocol, whoever you're working with, if they're newly bereaved, you can work with them from that lens of knowing the where they can get derailed and work in a more preventative way. Okay. The Center for Prolonged Grief is the only place where you can get the 2 day. We have a 1 day intro to the treatment protocol, but the 2 day on its own is sufficient and what you really need to be able to begin to implement it. And it's at the Center for Prolonged Grief at Columbia University, but all of the trainings are now virtual, so it's accessible to anybody anywhere in the world, actually. I am an affiliate of the center, not an employee, and my endorsements these are not paid endorsements, let me be
Yeah.
clear.
Yeah.
Um, but I am one of the co-facilitators of the training, of the continuing education training. There are about 8 of us at this point. And so that's the place to get the comprehensive training, and also to get, there are case consultation groups that happen a few times a year for people to try to get their sea legs for working with the protocol. And I also do consultation with individuals who are interested in an integrated multicultural perspective with the treatment protocol.
For someone that's listening whose interest is piqued, they can do the 1 day option, but the 2 day option feels really more comprehensive.
The 2 day training is required in order to understand the treatment
Yes.
protocol. The 1 day you get an overview of PGT and an overview of the treatment protocol, and you get an assessment package that includes, the typical beliefs questionnaire, inventory for complicated grief, that type of thing. With the 2 day training, you get the manual that tells you session 1, you need these. It's your blueprint, right?
Yeah.
It's the manual that was developed for the studies, the research that was done. And you get all of the assessment tools. You get a lot more. You get everything that you need to implement the protocol. The case consultation that's offered can be individually, but also there are groups now that happen a couple times a year for 6. You can opt in for 6 or 12 for that, and get support from the same people who co-facilitate some of the same people who do the co-facilitation of the trainings. And they're all really highly skilled clinicians, all of them. Mhm.
Is there a certification track beyond that?
Track because it gets complicated when you're in a university setting to offer certification that's not connected to uh, um, the in this case, say the School of Social Work. It's a little bit different, and more hoops to jump through. So there's not a certification. Um, Independent, there are a lot of certifications, or several in grief loss that, are independent of universities or colleges and don't have to have, anybody can have the certification program,
Okay.
you know.
I do know. There's
We
there's a
both,
lot of
we both know. Yeah.
there's a lot of certifications out there that um well, you wouldn't necessarily be further along in the process if you got one. So I think it's good to hear that you'd be on your way and able to access consultations at that point after
Yeah.
that
Right.
2-day
Right.
training. Yeah.
Absolutely. Yeah. Yeah.
I want to also just give you the space to share some of your concerns about some of the loss that we may be facing as a country over the coming years.
Yeah, I appreciate that. Thank you, Lorraine. When the pandemic happened, when we thought we were going to be, close to home for 2 weeks in March of 2020, and then everything would just be groovy again, um, the impact of that, the incidence of everything, been an increase in PTSD, depression, anxiety, so many things. And also with prolonged grief, people getting derailed from their already complicated grief process, pre-pandemic, if you will. So many of the factors that put us at risk for prolonged grief were present in the pandemic. Um, Getting stuck in guilt. For example, a lot of people, because they were denied the opportunity to be with their loved ones for reasons, most of us understand. When we're denied the opportunity to be with loved ones, we don't always get it, but when we're denied it, it has a really negative impact. There
That's
were,
a great point.
yeah, multiple losses. Some people in the beginning, before there were therapeutics or vaccines, um, would lose, multiple family members. They may have been an essential worker, okay, and so they had to go to work and they came home, may not have had symptoms and infected the whole family and lost both parents, a uncle or a sister, and so the multiple losses, the sense we already feel guilty when a loved one dies, so we should have done something to have prevented their death. And in these cases, you accidentally, quote, caused in part, that type of thing. The lack of social support is so incredibly important when we're grieving, appropriate social support, and not being able to gather together, had a severe impact on us in grieving. The loss of the assumptive world, those secondary losses that, if I do A and B, then C and D will happen, that type of thing. So, and the cumulative grief and the disenfranchised grief, the lack of acknowledgement of the denial of what was happening. Um, so there was a lot that happened with the pandemic that increased the number of people who had more complicated grief experiences and thus met the criteria also for prolonged grief disorder. Stoke division or call people out, but just to speak truth. With everything that's happening when our government right now, all of the changes that have happened in just a short time and will be implemented over the next 3.5 years will result in an increase in death. People being cut off from Medicaid, people who are disabled, who need that insurance, Medicaid, to get the treatment they need to literally stay alive. People who are going to be cut off from their commercial insurance plans, if you
Yeah.
will, and so that people are going to be less likely to get the care that they need and develop more acute and chronic illnesses. Um, what's happening with changing the reversal of Roe versus Wade. What's happening is because the one of the procedures, the D and C, that can be used for abortion, voluntary abortion in the first 12 weeks, is also the procedure that's used to care for a woman after having a miscarriage.
A missed miscarriage. Yeah.
Yeah, and so they're being denied that treatment because in certain states, that it's considered, quote, illegal, and doctors can be imprisoned for life if they perform the needed surgery. So women are being literally told, go out and sit in the parking lot until you're about to bleed out and then come back in. So that's happening. There's so much that's happening with the communication around vaccines. So fewer people. We have a severe measles outbreak, not an epidemic yet, of children. Children are dying when measles had thought to have been eradicated the year 2000. So there's so many things that are happening that are impacting our lives, how long we will live, literally. I could go on. There's so much. All of these factors, like the pandemic, are in place now. And so we're seeing there's so many factors all at once that we're going to see a lot more death and a lot more complications associated with the death.
Yeah.
And so we need more people who are able to join us in helping people to heal.
Yeah. You're seeing this opportunity for mobilization
Yes,
and
yeah,
and to just let people know what the process is, what the treatments are that people could be aware of for when these clients inevitably come to us
yeah,
and need the treatment.
yeah. And during the pandemic, so many other therapists. I was a moderator of one of a therapist Facebook groups during the pandemic. They had over 10,000 therapists, and it was a member of many other ones. They had large numbers too.
Yeah.
Um, and there was so much around mobilizing therapists in terms of trauma training to help with the trauma. I was one of those that's when I began to do some training in trauma related therapy techniques also. So we've mobilized around that piece. We need to do the same thing as it relates to the trauma of the loss of a loved one,
Yeah.
you know?
Yeah, I
So
think it's really valuable to just point out that it's a specific protocol that I know a lot of people don't even know
yeah,
exists.
yeah, yeah. I didn't know about what it was called traumatic grief when it was. And I've been, into the 90s, early 2000s, and I've been licensed almost 10 years then. you know, um, and was teaching at an undergraduate level about grief. But textbooks, even still today, include the 5 stages of grief, and not a lot else. You know what I mean? You
Yeah.
really have to be curious and dig to learn more, which is how I began to learn about the complexities of grief beyond, the idea of 5 stages or whatever else was out there then.
Yeah. Can you talk a little bit about the 5 stages and some of the concerns with that model
Yeah.
that so many people know about?
Yeah. So it's woven into the fabric of our society. Um,
Hmm.
we hear it all the time. We see it on TV, and journalists do it in their articles, and so on. And therapists use it also. Elizabeth Kubler-Ross, who is a psychiatrist, very well respected for the most part, until she started working with. She died in 2004, but she started working with children, infants with AIDS. Okay, and was a little bit ostracized for that. And then she began to talk about near-death experiences, and people sort of, said she was going off the deep end, and you're just destroying all the work you've done around helping us to understand the needs of the dying by talking about we don't really die, and all this woo-woo stuff. But for the most part, because of what she offered us about the needs of the dying, was quite revered. She connected with David Kessler, who had been working in hospice, and at the time that they met, 9 years before she died, after she had gotten really sick, started having strokes, um, he was writing a book on the needs of the dying. So they connected and had a very wonderful mentor-mentee relationship, and she invited him to write. And this is what he tells. This is his narrative. And she invited him to co-author her last two books. And so the book that they finished the manuscript a month before she died. Okay, on that book. And so he's carried her legacy and has great respect for her. So people connect him with her and the theory, but there's so much research that refutes any validity to it for many, many reasons, including that it's harmful to share it for people because it isn't just that grief is not linear. It's that grief is much more complex. And to talk about these might be 5 feelings that you might have all at the same time. What does that give us? Why might people experience anger? What if they don't? Depression. Well, if they go through depression, is that major depression or just a different type of depression? What does that mean? What is acceptance? How do we get there? Why do some people have different experience? It just doesn't offer anything. And so what I believe, a lot of people feel because grief is normal, it's normal to grieve and necessary to grieve too. I want to be really clear about that. We don't need to know anything. If we survived the death of a loved one, we're experts. But it's kind of like adolescence. Craziness in adolescence is normal. Okay, it's a developmental stage. That's why we don't diagnose personality disorders when people are adolescents. But in order to intervene appropriately, we need to know what's normal craziness in adolescence, if you will, and where the kid may be going down the wrong road, and there needs to be an intervention. It's the same type of thing with understanding grief. So we have to understand the development of childhood, including adolescence, right? And for example, drug use experimentation may be normal, but when might it become a problem? So we need to have all this other information. It's the same thing with grief. A lot of people think if they survive raising adolescents and everybody's safe and nobody was behind bars, then they're experts. That's not the case. And I think what happens is in our desire as therapists to really want to help people, the idea of these 5 stages of grief, it's simple, it's, quick and easy. We feel like we're helping, we're giving them something. And I think it serves as negative reinforcement for therapists. It takes away the unwanted feeling of not being able to alleviate somebody's suffering. Okay. By offering this theory, it takes away our discomfort. Okay. And so, again, because I work with people who have been stuck in their grief for some time, suffering for some time, they say, I don't know what's wrong with me, but I didn't have the 5 stages of grief, or it just comes up all the time. And I say, okay, no stages of grief. I promise we'll talk about that more, but there's nothing wrong with you that you don't fit that. It doesn't fit. It's so much more complex. And then some people will say, well, who cares which model is correct? People just want them to help you. We can't appropriately help people if we don't have a solid foundation in the why. Why are they grieving? Why are they having complications? How can we effectively intervene? So it's a very, it's used all the time, and it's applied to non-death related losses too. Elizabeth Kubler-Ross initially intended for that to apply to the needs of the dying, and there were more than 5. There were like 13. And then she did at some point say, I think this applies to grievers also. Any of us can offer a theory. A plausible theory is one that can be put to the scientific test. And so what has happened is this theory has been tested and refuted. And there are many more plausible explanations for why we grieve that we should be using to help people.
In the evidence-based research, you have a great article that I'll link in the show notes, but in the evidence-based research, it hasn't been stood up to the studies that have been applied to the 5 stages of grief.
Yeah. Thanks for reminding me of that. I forgot that I shared it with you.
I think sometimes our clients benefit from that permission that any feeling they're having is part of their grief process. I think sometimes there can be some shame around any feeling of relief, any feeling of, any mixed emotion, any anger that's coming up. And so that's one thing, to be able to give that support. Yeah, that sounds like it's a part of a necessary part of your grieving process versus uh, referring to it in a stage theory sort of manner, or that
Right.
they're required to move through in some order.
Exactly. And we think there are many theories that focus on tasks or milestones that we need to accomplish in order to adapt to the lifelong reality of our loved one no longer, or loved ones, plural, no longer being here, and tasks that we need to engage in to restore a sense of well-being. Kathy Shear and the motto of prolonged grief therapy talks about them as milestones. William Warden talks about them as tasks. Teresa Randall talks about them as the 6 R's. Alan Wolfelt has a set, also talks about task. And so it's more helpful to think about this is what people need to be able to accomplish or to do, or these are the goals to be able to adapt to this profound loss and restore a sense of well-being. And so it's more than just the emotions.
Yeah, that's a great consideration. Switching gears a little bit, are there any responses that you hear from clients have been more or less helpful in terms of support after suffering a loss?
What type of support have they found to be helpful?
Yeah.
Oh, so let me just say that one part of the prolonged grief treatment protocol is bringing in a support person for a session. Okay, and talking about what prolonged grief is, and talk about ways they're already supportive and ways that they might be, explain what the treatment protocol is and what they might need in terms of support. And I always let them know it's not your job to fix a person, it's your job to be present. That's invaluable, and to try to understand. And I didn't mention earlier when we were talking about the evidence-based prolonged grief group therapy treatment protocol that Catherine Supiano created based on Kathy Shear's prolonged grief therapy treatment protocol. And in that group session, it's a 12-session treatment protocol. They have support people come in on 3 different occasions. So there's even more support or opportunity to shape the ways in which people understand prolonged grief and show up as supportive. But what people tell me consistently, and what my experience has been personally with my own grief-related experiences and those of friends and family, is that people try to fix you. Okay, or people try to offer things to do or suggestions, to help you just snap out of it, And what people need is for you to be able to hold their grief with them. And you know what? As humans, we have to be mindful of our own boundaries. That's something else that I share with, the support people. Um, because we absorb other people's energy, and so we hold their grief. So we need to be mindful of what we have the emotional bandwidth for, and how often and all of that. But they need us to be present with them. Clients say all the time, I've never been able to share that story with anybody else. I've never been able to sob in that way, to cry an ugly cry. They share, sometimes I feel like I was afraid I had to take care of my therapist, that they couldn't tolerate it. And so what's most helpful is being able to hold their grief, to not try to fix it, not to try to say, well, God called them when it was time, or
they're in a better place.
Right, you're in a better place. Oh, you're young, you can have another baby. All the things that, we mean well, but, it's not what they need. So we need people to be present with us and not judge. Okay, a lot of, people talk about feeling judged. Like, it's been 3 years. You're still grieving over, like, y'all weren't even that close. You argued all the time, kind of thing. So we need tolerance, and we need to become more grief literate. We need more grief literate support people in our lives. One of the things that I try to do too, and it's difficult, is to empower people to try to figure out what they need and to ask for it. And it's hard. It's really hard. Because we're particularly sensitive to rejection, because we're in a fragile state. Even if we have had a secure attachment style, after the death of a loved one, at least it's an attachment disruption. We're not as, sure, we're not as comfortable with other people. But if we can just say sometimes, I don't know what I need. Can you just listen? Or can you just hold my hand? Will you just hug me? Can we just make some popcorn and sit in silence to try to identify what we need or what we don't need? Please, I don't need you to try to make it better. I'm okay with you just being present. Can you just listen? And as supporters, we need to ask, what can I do to help you? What do you need in this moment? Do you know what you need in this moment? We often will do for people what we would want people to do for us. So if somebody says, they pull the shades down, I don't want to see anybody, and I think, oh wow, I couldn't stand to be by myself. I'm just going to go ahead and cook a good meal, make a pan and a lasagna, and I'm just going to go over there unannounced. No, no, and the other thing that's really important, that's really hard, is we need people to keep showing up even when we say no. Okay. And again, speaking about reinforcement, when you consistently say no, you can extinguish a behavior very quickly. Okay. So people say, I've tried X, I've tried Z, I've tried A, I'm done. Okay. So I try to help grieving people to be aware of that it's not necessarily a rejection of you, but we're animals. Okay. And human, but we're still animals. And so we need to be reinforced, for our quote good deeds. So it's complicated, but people want folks just to be present. Don't try to fix me, you know. But the other tricky thing is something that you may say to a grieving person today may be right on point, and that person's so appreciative. And you say the same thing 2 days later, and the person's in a different place in the moment, and they're offended by it. So it's difficult. It's difficult. So I encourage people to when support people, individuals, or they can bring a village if they want to, a support session or two, to come up with ways, like to use emojis, for example, to communicate how they're feeling. Like the poop emoji might mean if they reach out and say, do you want to talk? And that can mean, I love you and I appreciate you reaching out. I'm having a crappy day. Okay. Or, whatever it is. And so people end up having fun making up their own language in that way.
Yeah, like a code word in
Yeah,
an argument. Yeah.
right. If you reach out to somebody, sometimes grieving people want immediate responses, and people can't always do that. So if you can send a sunshine, that means I love you. I saw your message. I'll call you as soon as I'm able. Whatever it is,
Yeah.
to have to negotiate that. But it gets complicated.
Yeah, I think I'm hearing a message for people too of it's not personal. Try
Right.
some different things, be
Yeah.
a little bit creative. It's
Yeah.
not about you. Don't personalize it. It's just part of the process. So
Yeah. Yeah.
be persistent if you can.
In a way that doesn't violate your own boundaries. And you know what I
Yeah.
mean?
Yeah.
Um, Yeah, we have to be really, we all have limits, and holding grief is really hard work. And I'll say this as it relates to being a therapist. We are called to do more of our own work outside the sessions to be able to be present to people, but even beyond that, to take care of ourselves. And it's sort of a responsibility, but a gift. We must do our own work to be able to do this work. So that makes us all better people. It serves our highest good.
Yeah.
I do massage and energy work on a regular basis, and I have some other practices that I engage in to try to um, stay elevated and clear as much as possible the intense grief, that is required to hold with people who are
Yeah.
grieving.
That's a great segue into the question I ask everybody of what do you do for self-care, and is there anything that you find that you recommend in terms of self-care to your clients?
I think energy work is so important. From a trusted, practitioner, and things that you can learn, on your own. I think that's really, really important in terms of clearing from your body the weight of the grief of other people, and your own grief. We all have grief,
Yeah.
death related and otherwise. And brain spotting is another. I'm a brain spotting practitioner and I do self brain spotting. Therapy from time to time. I think every good therapist needs to have a good therapist on speed dial. Though we don't have speed dial anymore, I'm dating myself, but you know what I mean. Readily available.
Right.
Um, and meditation. I go through periods of, stretches where I'm like really, really, really consistent with, and other times I'm quite sporadic. Yoga sometimes, again, same thing like with the meditation. And then, connecting with other people, singing, music, singing all the time, just for me, not for, um, just for me. And that's all the time. Everything's a song in my head too,
Oh,
but that's
yeah.
another story. And I love doing jigsaw puzzles. It's like meditative for me.
Yeah.
I'm looking at one over in the corner now that, but I sometimes have trouble giving myself permission. That feels like too much fun. But yeah, and again, connecting with people, being with my loved ones, and laughing. I love laughing. And my sister is a person I laugh the most with and enjoy the most, just hearing her laugh. And we can laugh about the dumbest things,
Yeah.
for hours. For hours. I can do that with my friends too, but she and I, we've always had that. And it's just the two of us. She's my only sibling, and both our parents have died. Though we have other relatives, we've always been really, really close, and even closer since the death of both of our parents. So we laugh a lot together.
Backing up to the prolonged grief group work,
Yeah.
what is the training process, or where can someone access information about that as well?
Great. Thank you for asking me about that. It's through Caring Connections at the University of Utah in the School of Nursing. This treatment protocol, there's a page, Resources for Professionals, that you would click on. Kathy Supiano just retired from the department maybe 2 weeks ago at this point.
Wow.
And her dissertation, I think back in 2012 or 2014, was on this protocol that she created and working, again, in consultation with Kathy Shear. So it was the foundation, her dissertation, and she's done a lot of research since then to support the efficacy of the protocol. Laura Bradbury, excuse me, is now the director there. Both of them were social workers. Laura is now the primary trainer there. A few other really, really excellent trainers. Aaron, I believe, the training's excellent. It's a one-day training for the prolonged grief group therapy protocol. There's a manual that you get, and there is a participant manual that you can obtain from them, but you get the facilitator one with the training. They also have a lot of other trainings. They have an 8-session group therapy model, support groups for people whose loved ones die by accidental overdose, and then those that die by suicide. So there are a lot of, those are some of the other trainings that they have, and I highly recommend. And they're free.
Oh,
They're
wow.
free.
Okay, that's a great resource, and encouraging folks to get
Uh-huh.
involved. I think accessible training is
Yeah,
such a big part of it.
right. Yeah. I just want to say again that this is hard work for the grieving people, for the grievers, and for the therapists. It's really hard work. Each of us has our limits. We're not good at everything. We're not cut out for everything. You know what I mean? But if you are called to do this work, um, it is incredibly, it's sacred work. I think all therapy is, but there's just something about this work. I guess it's like that with any trauma work, really, but it's just sacred work with people, and to have the tools to help them to heal. These are people often who have been stuck for, like I said, sometimes more than a decade, for so long. Anybody who thinks they might want to, or who may have gotten a hint from the universe that said this is your work and you're not quite sure, you might want to explore it.
Yeah, check it out.
Yeah.
Okay. Well, Sonia, thank you so much for your
You're
time, your
so
wealth of
welcome.
knowledge. When I listen to you, I think, do I know the names of the people whose work I'm citing? I mean, you're so good at it. So I've really enjoyed getting to know you more and having you on. I appreciate your time.
Oh, I appreciate you and your time as well. And I'm so grateful. I'm so excited about this podcast that you've developed and the importance, because, it's so important for us. We can't know everything about anything. And it's so important to offer sort of the sacred platform to encourage us all to continue our learning. So thank you so much.
Thank you. I
Okay.
appreciate that.
All right. Take good care.
I hope you enjoyed this episode of the Self-Carapist podcast. If you did, please subscribe and feel free to leave a review. You can also follow along at the Self-Carapist on Instagram or head to lorrainemoorhead.com/podcast to grab a free copy of your own learning map worksheet to help track all of the tools and strategies you're interested in learning more about. See you next Wednesday.